So first of all, I'm going to do a bit of advertising. So this is the clinical session. If you're expecting anything else, you're in the wrong room. We run some regular clinical webinars. So we run clinical, we run implementation, and we run research webinars. There's a URL which is very easy to remember. So it's just snomed.org/web series. Please go on there, have a look. If there's things that interest you, obviously join. For those of you who are either speak Spanish or are bilingual, we've started a Latin American network that have been running regular webinars. The webinars are in Spanish. The one which is scheduled for May, which is May to everybody else, is based on the experiences in El Salvador. The same with that. If you're interested, the details are on the webinar series and on our website. I'll do a promotion for me with my other hat on. We're running literally a one-off conference in Brussels next month, from the 22nd to the 23rd of May, looking at SNOMED in Europe. SNOMED International is doing a very, very small number of presentations. Everything else is really from either clinicians within Europe or national ministries that are using SNOMED throughout Europe or the Commission themselves. The webinar is a hybrid, so you can come and visit us in Brussels because we'd really like to see you. But you can also register and basically visit it online. So have a look. The agenda is on the website. Have a look at the details. If it interests you, then please join. Last of all, but last but not least, we have our expo, which is in October, the end of October this year in Seoul in South Korea. The most important bit, we have the call open for the moment for abstracts. So please have a think about whether or not there's anything you wish to present, and submit your abstracts. Which brings us on to, that's all the advertising out of the way. So I'll bring it on to where we are now about the webinar and the clinical bit. With Lucy, the three of us, so my name's Ian Green. Most of you, I think, know me, looking around. I'm the customer relations lead for Europe for SNOMED International. I also head up clinical engagement for SNOMED International. And I have with me my two esteemed colleagues. So I have Dr. Charles Guttridge, who most of you know in person or by reputation at the very least. So Charles works for SNOMED International as a clinical engagement lead, and in his spare time is also the Chief Clinical Information Officer at Barts Health, one of the large hospitals in East London. And my other colleague, esteemed colleague, is Jane Millar, who most of you know, who dabbles in collaboration and clinical engagement, and is a reformed physiotherapist. Yes. What?
I'm not sure that I do know everyone, because there are certainly some new faces here. There are, of course, some very welcome old faces. But I thought I would just say a little bit more about myself.
Okay.
Is that all right?
That's fine.
Just to swank a bit. But the reason is that you're sitting in Bishopsgate, and literally about 100 yards that way is an area called Spitalfields. And it's called Spitalfields because it was a spittle in the 12th century, in other words, a hospital. And it was outside the city walls, and it was a leper colony. And obviously we don't have leprosy in East London anymore, but we do have an extraordinarily wide range of people of all descents living from this point here right through to basically where the Thames enters the North Sea. A very, very vibrant community with hundreds, about 100 different languages being spoken every day and coming to our set of hospitals. So Barts Health, for example, it's not the only trust in East London, but it's the biggest in East London and one of the biggest in the NHS. It has 5 hospitals. Barts Hospital, which is that way about a kilometre, founded in 1123 by a priest. It was basically a sending off place for pilgrims who thought they were going to get to Rome and get a blessing from the Pope and realized that actually they weren't going to get that far and would be better off dying in the old hospital. So that's where it started. But then there's the Royal London Hospital and some other hospitals further east that we all run on a single network. And the reason I wanted to emphasize it is that we are now, like everybody else, a data generator. We literally produce billions of data points a week, a day, a month. It doesn't really matter what the time scale is. But the agenda for us now is to find ways to really use those data for the benefit of the people we look after. And we formed a data science group, a life science organization which has its own buildings, its own staff, and it is hoovering up our real world data and using that for public health purposes, for population health purposes, for individual decision making and so on. I don't think that's different to what anybody else is doing, but I suppose what I'm trying to get over to you, that I'm not just a sort of Ian Green clone trying to make SNOMED happen. I'm trying to make SNOMED work for people in real care situations. And I would guess, as most of you are at the clinical interface, you know how hard that is. It's how hard it is to persuade people to use the terminology in real time at the face with patients, because using a terminology gets in the way of that conversation that you have with patients, which is often deeply personal. And a screen, a keyboard, a mouse, and a terminology definitely blocks that bit of engagement. And it's why it's so hard. And if people say to you, well, shall I do it after I've seen the patient? I always say no, because I know they will never go back to it. You have to do it live, and you have to generate ways of being comfortable with your patient. And I think the route into that from my own personal practice is that you make the recording of somebody's life a joint endeavor. So you show them what you're doing. You turn the screen towards them. You make them part of that. Here's what you look like from a data point of view. And it's okay. Or it's not okay. So that is a way into the conversation about the seriousness of disease, the seriousness of diagnosis and so on. And of course, you can then show all sorts of additional things which illustrate what you're talking about. So I was a hematologist. One of the great pleasures for me was just simply showing people a graph of their platelet counts. And you could say, look, your platelet count fell there. Did you stop taking your steroids? And they go, oh, doctor, how did you know that? And those sort of conversations make you human and appear like a genius to the individual. And it's really simple. And those are the magic bits. And then you can begin to do what we're doing, and I imagine, again, many of you doing, but is sharing that information online using various portals. So I'm personally also a patient, and I was just showing Ed earlier the fact that I just made an appointment with some ENT guys at my hospital who hopefully will fix my voice in a few days. And the conversation turned into a message to my account in my patient portal sharing thingy, telling me when my pre-op assessment was within 30 seconds of the clerk doing it. And I think that bit about how you can use those data then to see what you're doing, how you're improving the pathway of care for patients is the magic of SNOMED in particular, and how all of that fits together. Because unless it's structured, unless it can be grabbed from the record in a meaningful way, none of that is possible. And so, you know, a lot of my colleagues think I'm a nutter. Really, they say, oh, he's the SNOMED guy. But this is really serious for patient care, and it's in your hands to deliver it. And so one of the things Ian and I and Jane are trying to do is to build a network of clinicians who are like me and really, really want to utilize the benefits of data for the purposes that I've just set out. So I'll stop there. Jane, I don't know whether you want to do a whole physiotherapy thing, but...
I'm not following you.
I'm not sure who manages who, but we'll kind of leave that as it is, all right? So broadly speaking, we put the agenda together really just to give you as the community a bit of an idea what the existing clinical reference groups are. We'll talk through a bit from our perspective about requests we've had for new clinical reference groups, a bit about where we're going with clinical networks. We'll look at some of the future, particularly in regard to some of the requests for broader scope clinical reference groups. I'll give you some time to think about this. Jane's going to talk about the clinical implementation guides. So, whatever. We'll talk about getting involved and, you know, exactly where Charles has just gone with that, but looking at going forwards how you can become involved. Although there isn't, you know, it's not on here, there's also time for questions from either those online or those in the room. So I'm going to shut up at this point and hand over to the first on my list, who I'm looking at. Marie Alexander, would you care to take the stage? All I've got to do is find your, hang on, I've lost the bloody thing. Oh, here we go. Okay.
Does it work like this?
Is it on?
Okay.
Yeah.
So I'm Maria Alexandra. I'm a co-chair of the Allergies CRG. I'm not an allergologist myself. I used to be a pathologist, but I'm actually chairing now a community of practice in Belgium of hospitals who have teamed up together in their wish to implement SNOMED CT and also SNOMED CT and FIRE together. And this has brought me to the Allergies CRG because it was the first very simple use case that we wanted to try. It was the low-hanging fruit for hospitals. The allergies are important for everyone, and it's not so difficult to get an agreement between people of what is the smallest set needed. So it was a very good use case for what we wanted to do as beginners. And so I ended up in the group, which is a very nice group chaired by Bruce Goldberg, which is an esteemed allergologist. And so what are we doing now? I'm going to start with the last, well, it's the second slide, so I'm going to start with the last 9, is the update to the allergy, hypersensitive, and intolerance guide. Okay, you can leave it there, yeah. That's one of the guides Jane are going to talk about at the end of this session. It's actually an hybrid guide where we talk about not just using SNOMED for allergies, but also about data models for the global structure of the data that hang on together with recording of allergies, and also how to exchange those data. And we go into the exchange using FHIR. So we believe strongly that there is a future for guides where you not just you talk about SNOMED, but also about how to exchange those data, because ultimately you want your data for your own, but you also want them to share them. So this is one thing that we have done, and we stand open for any comments and improvements, and we will likely continue to work on this guide to further enhance the reach, especially regarding the links to the other FHIR resource, which are allergy testing and observations in FHIR. The more allergy specialist content we are going to work on this year is improving the modeling of the immune hypersensitivity disorder content to align it with the latest scientific discoveries, I would say, or scientific classifications. And there are several issues with the current way some concepts are modeled, which I will not go into here. And I welcome anyone who would want to go to the allergy CRG. If you're not allergologist, well, I wasn't, and I've been there for 5 years, and I've learned a lot. So please do join us, and you will. It's a very fun group, very nice group, and you will learn a lot of things about SNOMED. Can I have the first slide just, and then I'm gonna, as Ian said, shut up. There is a first slide about LOINC. There were 2 of them. No, there were 2 slides. Anyway, the other big thing that we are going to work on is working on LOINC EGA testing content and see what can be brought into the SNOMED LOINC extension from that content with what is interesting and not yet represented in SNOMED CT. So this is going to be a big work, and we welcome any feedback from all the member countries about what is important as EGA testing, which sometimes vary from one country to another depending on what's available commercially. And we will also do a lot of smaller things, but I think my time is more than up, so I will leave the floor to the next one. Just Ian forgot to mention, when there is the SNOMED in Brussels Congress, so the SNOMED in Europe, sorry, the day before in the afternoon we will be holding a smaller meeting which will be about the use of SNOMED and FHIR and about all the new European health data space things that are coming into places. So you are welcome to join us there also. And thank you very much.
So we'll go on to the next one, which isn't a clinical reference group, but it's, we have a group looking into. Sorry. So the next one up is Scott Campbell. We have a group looking at cancer synoptic reporting, and Scott, in his usual way, hasn't sent me any slides.
You never asked.
It's an admin issue, don't worry about it. But Scott will
good
run
at
through basically where the group's going over the next, well, the remainder of this year. There you go.
Sure. And Marie Alexander used to be a pathologist, but she became allergic to formalin and wax. And so she had to leave pathology for allergic reasons. And so, yeah. See, there you go. Now we know. So, all right. So I'm with the Cancer Synoptic Working Group. You've probably heard a lot about that. We're representing and we've developed all the content the vast majority of all the content necessary to represent all data elements on the published data sets by the College of American Pathologists and the ICCR, International Collaboration of Cancer Reporting, which represents basically most of the rest of the world. And so the terminology by and large is done. What we're doing now is we are working with the 2 publishing bodies of the data sets and supporting member nations to bind and validate the terminology bindings that we've developed as part of our group, ensuring that they are fit for purpose and teasing out any nuances in the advance or in preparation for distribution of SNOMED content with those publishing bodies. So with the College of American Pathologists, we are 18 data sets out of 60 have been validated. Pathologists are engaged with that, and that will be incorporated into their North American release, so all of the US and Canada, with the exception, I think, of Quebec, just because they don't speak French yet. And then with the ICCR, we're doing that, and at the same time, we're starting to work on the organizational agreement between the ICCR and SNOMED to make sure that everyone's IP is protected and properly. And there you go.
Thank you.
You're welcome. Oh, I guess one more thing. Sorry, no, because I always forget. The synoptic group is spun off other groups. So we're also doing a massive quality review and remodel of the malignant morphologies that are represented in SNOMED. So the goal there is to make it congruent with the Blue Book version 5, and while maintaining the SNOMED components that are necessary in terms of the ontology, and then letting ICDO do what ICDO does, which is count things. Okay.
Whoops. Do you want to stay there a minute, and you and I can talk about pathology?
Do I have
Because
to
we
stay
haven't
here
done
if we're
slides.
talking? I know.
So we have a group, the Pathology Clinical Reference Group, which has been meeting literally every time this organisation meets in person. We haven't been meeting virtually in between times, really because Scott and I look at chairing the meeting, and it's difficult to ascertain exactly what the agenda should be for a group whose scope is that broad. We met literally this morning, all morning, the group's been meeting, looking at how we move some of this work forwards. The big item of discussion, which in some ways is not surprising, was the SNOMED Reagan Street collaboration. So looking at SNOMED on one side, LOINC on the other, both in terms of the work that's going on, but also in terms of where that ultimately will go in terms of implementation, how that fits into existing LIMS systems, pathology messaging, et cetera, et cetera, et cetera. I think that one will be, and the answer, I don't have an answer to those questions. I do have the task of trying to pull together a group to work out what the answer to those questions is, which is something that we're working on in the next couple of months. The other side of that is something that I'm going to cover later in this session, which is the broader question about where that group should go and what it looks like. But let me cover that in the slides to come. Scott, do you want to add anything to what I've just said?
Sure. I guess it's an oddball place because we have corporate agreements and reasons, and those exist for a reason. We have national needs that don't stop for organizational, for corporations to figure themselves out. There's lots of history. And the question was brought up, well, how do we get people to engage? And this ties in a little bit with what Ian was saying, but in such a broad area, what I found is that when there is something that people can rally around, that has in which we can also circumscribe boundaries. I know, go figure. This is for the mental health group. We're going to talk about boundaries now, but so that we can actually have real project focus, and people that can defend it, make sure that we don't cross boundaries. Then these things tend to work out. So there could be a couple options here. One of the thoughts was, well, do we look at something that's important to the SNOMED community in general and the LOINC community in general, that is and where both terminologies are used very frequently, and that would be microbiology, for example. It's hugely important. We just came through, a nightmare. But how do we deal with microorganisms? How do we deal with the testing in the lab, reporting that information out, getting that information to the public health authorities where necessary, determining when something is or is not developing resistance to a nasty, to an antimicrobial, for example, that becomes a nasty issue. So I think there's a lot of people who are interested there, and what the Cancer Synoptic Group kind of taught us is that when there is something that is very, very important to a large group of people, and there is a largely agreeable endpoint on which you could get to through multiple directions, but ultimately an endpoint, that ends up being very successful because you have experts who are willing to donate their time. They know this is important. They are experts in the area, and they do seem to come out of the woodwork eventually. So that's something we need to contemplate, but that might be a neutral area. I mean, we deal with the organisms themselves, we deal with the substances, and now we would necessarily have to deal with the lab tests. It might be a nice convergent zone and a place to collaborate. So just a thought. That's it.
Thank
Unless
you.
Want me to say anything else?
No, that's fine. You are dismissed. Mark, dentistry.
So I have to start with just a little comment about Dr. Gutteridge's idea of sharing the information with the patient record, and it kind of brings tears to my eyes just thinking about something like that, because if I turned virtually any electronic dental record towards the patient, what they would see is, this is what I charged, and here's what you've paid, and that would be about it. We just have very poor record systems in general. That's changing because the medical world has recognized that who have developed electronic health record systems recognize that there may be some other places that they can start putting record systems in place, and dentistry is one of them. So a lot of what we're doing right now in dentistry, as well as the SNOMED portion of it, is to try to get those record systems working and functioning so they can actually take medical information and dental information and try to make it work together, much like Charles talked about. So what we've been working on is a number of different projects actually for the last few years. One of them we've been working on for about 2 years is our procedures hierarchy. Again, it's one of those things where much of what is in the procedures from the old read codes and from the old CAP system were probably developed in the 50s, 60s, and 70s. And things have changed a little bit. Our substances that we use have changed, our methods have changed, and we just have to bring it up. So it's a quality assurance project that's taking us a considerable amount of time, but I also think is going to be very important to the end result. The second thing we've been working on is a project to assist mostly our orthodontists, people that are straightening teeth and things like that, to send records to each other in a reasonable fashion. So we're working with another entity that DICOM has, or that SNOMED has an arrangement with DICOM, and trying to make sure that the proper methods can be developed for communication. So we've been developing a number of different concepts to assist with that. I think we're getting very close to being done. We need to have probably a meeting with the DICOM representatives as well as the orthodontic representatives to finish that up. But I would be disappointed if we didn't have that completed before our meeting in Seoul. That said, about the time we finish that, we have a group of forensic experts that now want to be able to send information in a similar fashion, and they have a number of different needs. So we'll kind of finish out one and probably be looking at adding another. The last area is one that I'm really pretty impressed with how we've gone about it and the information we have to work with. We developed our first dentistry ref set a few years ago. It was specifically designed for general dentists. And what we've changed in it, and we're looking at how to make that changes. And even though we have a very limited amount of information, in many cases, much like I talked about our electronic record, we do have a number of universities and a few private entities, as well as national organizations that are able to provide a lot of information. And in designing our new general dentistry ref set, basically to represent findings and diagnosis specifically, we were able to come up with about a total of about 20 million pairs of encounters where we could look at both the diagnosis and the procedures provided. And this is the first time we've ever been able to get towards something to let us look at a tool that would say, if this is the diagnosis, this is the most common type of treatment that we provide. And so we're going to have a new reference set based on that, where we hope then we can start looking longitudinally over time to develop actually clinical decision support tools. We're trying to keep it very simple based on our most common procedures or our most common dental diseases, and it'll probably be a set of about 300 concepts that I think virtually any electronic record system could put in place. And I think that's it for me.
Thank you. So the next one is not, so I don't chair this group, but the two that do chair it, one's had to fly home early and the other one's actually in the US. Whoops. So this is really to give you an idea of what the Nursing Clinical Reference Group does. The group meets on the second Tuesday of every month. It always meets at 8 o'clock UTC. It's really there to provide a global forum. So we do literally have global representation. So we have nurses from North America, nurses from Europe. It's a little difficult getting nurses from Asia because of time differences, and welcome to the world of international standards. It provides a forum really to look at the content in SNOMED relating to nursing issues. It has been, was one of the main groups focusing on some of the work that we did fairly, well, a while back, although it seems very recently. The work that we did bringing ICMP, so the International Classification of Nursing Practice, into SNOMED CT and the alignment work that went on with that. The link to the group is on the bottom. You'll have these slides afterwards. In terms of where this, where the group's going, if you like. So in 2023, a lot of the presentations, knowledge exchanges related to nursing documentation and diagnosis, as I've said, particularly on the back of the work that we did with ICN. Implementations using standardized terminologies and just simply identifying gaps in nursing content. Also, there was reference set development, looked at how that would be developed around catheter care and provided input into the editorial advisory group regarding some of the content changes, particularly related to nursing. Looking at the work that's going forward in 2024, one of the main areas of discussion at the moment is looking at other nursing classifications. So for those of you that are familiar, we're talking about NANDA and NIC and NOC, so the nursing interventions classification and nursing outcomes classification, and really how we move work forward with those classifications. There are some clear use case requirements from members for all, or either all three together or independently, those classifications. So we're looking at moving that work forward. Obviously increasing the clinical participation. So the nursing group is, has been growing gradually. Still provides a global forum for knowledge sharing, and it's quite an active discussion forum. Identifying use case and collaboration opportunities just to further work on nursing content. Particularly with an emphasis, though, on multidisciplinary discussion. So there's a number of items that have come up for discussion which are not just nursing items, if you like. So looking at where there's overlap with other existing groups or other SME groups that we can link in with to forward those discussions. So that really is an update. Feeling better, Jane? That's really an update on the nursing CRG. And I'm going to hand over to Tina, who I think is online. So Tina, do you want to share your slides?
I do. Can you hear me?
Yes, we can.
Okay, super. I wasn't sure if I was sharing my slides or actually,
I don't mind. You can share your slides, or you can
yeah,
send them.
let me try and do that, Ian. Okay, do you see my screen now?
Yep, we do. You good?
Okay, terrific. So it's a hard act to follow after all these very impressive presentations. And I'll be talking about our work with nutrition and dietetics, SNOMED CRG. Many dietitians, nutritionists use a coded terminology called the nutrition care process terminology. For the past years, we've been working on the integration of the NCPT and SNOMED CT, and that has happened with participation from nutrition and dietetics professionals in 20 countries and more that join our meetings. The majority of the content added for nutrition and dietetics care documentation is sufficiently defined in SNOMED CT. And here's my slide of disclosures. So I'm here as chair of the Nutrition and Dietetics CRG. After completing the integration of the NCPT 2020 into SNOMED, we've been heading into a new era with the NCPT project group being promoted to a nutrition and dietetics CRG. We're looking to be approaching priorities that emerged as terminology projects when we were integrating the NCPT into SNOMED. And our first terminology project is focused on the reorganization of the feeding dietary regime hierarchy. And here, we're looking to bring practice and logical sense to the content, address duplicates, outdated content, for example, enteral nutrition versus enteral hyperalimentation. There is some content where the meaning is not entirely clear, so we will be trying to understand that. We're identifying the boundaries of the content, what is in a concept and what should be excluded. And we're also being mindful of the use of concepts in HL7 standards, such as dietary regime. We have a work group of 5 volunteers who are doing the initial prep work, and that comes to the CRG for discussion and progression. Our second exciting objective has been the release of the first NCPT ref set. The first ref set contains nutrition problems, diagnoses, a very important data element for high quality nutrition care. And the next release of the SNOMED NCPT reference set will be in April of 2025, where we aspire to include the complete NCPT included in SNOMED. And thereafter, we will be maintaining that annually. And so the NCPT reference set, we're also looking forward to it being included in the free for use global patient set, which SNOMED International releases annually. And we've been engaging in various dissemination activities, including newsletter articles, frequently asked questions. There's also going to be a press release very soon about the ref set. We're very interested in tracking the use of the ref set in a systematic fashion, and we look forward to continuing discussions on how to make that happen. Our third objective is another very exciting area. We've just started working on developing an implementation guide for the NCPT. and this will function as a practical resource for clinicians and technical implementers. We will also be bringing our progress to the CRG members, but we're also at this moment we're also recruiting for volunteers to support the content of this work. Just as an example, I think of when over my time, I just want to show here what we've been doing because of the integration of NCPT in SNOMED. We've been able to develop an HL7 FHIR API where we are pulling data from an EPIC installation into the nutrition care and dietetics infrastructure that the Academy is maintaining. And we've been able to test this successfully in the recent Connectathon this past January. We're really looking forward to be able to start pulling nutrition problems using the same API. We're very excited to be progressing all this work. We meet every third Monday of each month, and I've listed our upcoming meetings and our URL to the Confluence site for our CRG. Back to you, Ian. Thank you so much.
Thank you, Tina. The only other group we have, but I don't have a report from them, so I'll tell you what they've been looking at. So the other group is mental and behavioural health. They've been focusing on particular content issues. So really focusing on the group on getting the group focused on discussions and getting them, like I say, particularly on particular content issues that have either been raised. They've been raised really by our own content team, but also via various discussions in terms of either points that have been raised by clinicians or points that have been raised by end users of SNOMED. Details of that, I'll show you how to access all the groups in a moment. The other group we have is eye care, and I'm going to let Jane talk about eye care. Yeah, okay. Ooh. Okay. Okay, so we also have an eye care group. The eye care group is focusing on diabetic eye care, so diabetic retinopathy. The group is a mixture mainly of clinicians from the UK, but the UK group has some international links, so it's not really just UK requirements, if you like. They're focusing on updating the content. The interesting thing about the eye care group, though, is also they have links to a number of vendors who provide solutions in the eye care space. So not only are we updating the content in line with clinical requirements, if you like, but also looking at real-life implementations of the content, which is exciting on one level, but also is very comforting that what we're producing will actually work. Anything to add? No, okay, that's cool. Right, let me get back to... Right, so where are we? Okie-doke. Let me just... Right. So that really gives you, a sum up of where we are in terms of the CRGs themselves. For those of you who don't know, so all of the CRGs have a Confluence site. To find them, let me just pull up this one, and then we can do this the easy way. So we have, where are we? So we have a central portal for clinical engagement, of which you'll get the link, but on the link here, it's very easy to remember, so just SNOMED.org/clinical. If you go on the clinical website, under it on the left-hand side, you'll see something called directory. If you open the directory up, there's hyperlinks to all the groups that will take you to all the individual groups. With each group, it will give you details of the meetings, documents, recordings of previous meetings, and a discussion pages for each one. So please, if you're interested or you know other clinicians that are interested in particular clinical areas, then please share those details. This is where I'm zipping out here, there, and everywhere. Right. So where are we? Right. So moving on to really, so that's from the clinical reference group's point of view, if you like. So looking from the centre outwards, one of the things that we get requests for is obviously for new clinical reference groups. At the moment, we have a number of requests which we're working through at the moment. The thing with all clinical reference groups and whatever requests we get, the requirements have to be international. So if there's a requirement for a group, it can't come from a single country. We have to try and get representation from across the globe, from the Americas, from Europe, from Asia Pacific, and Africa and the Middle East. At the moment, we've got requests for a neurology group. We also have requests for emergency medicine and surgery. The surgical one I'll come on to in a minute, but the emergency medicine and neurology, we're basically looking at how those groups will work, what the focus of those groups will be, and from our point of view, who will host them. So one of the things that we look at with all clinical reference groups is that SNOMED International doesn't chair the groups. So the reason why all those individuals came up and talked about their group, we're there from the centre to support them. I'll call it an admin function loosely. But we don't chair the agenda. We don't chair the groups. The groups and the agendas are set by the clinicians running those groups and the clinicians involved in those groups. So that's with the CRGs, with the clinical reference groups. As I said, we also have clinical networks. Now, I know that Victor Medina is on the line. Victor, do you want to say anything about the Latin American clinical network?
Yes, thank you, Ian. Hi, everyone. Yeah, we have been working in this clinical network for Latin American and Spanish-speaking countries since last year in November. We started with webinars with speakers from countries in Latin America which already implemented or are members of SNOMED International. Now we are going to run the third webinar in May, and the participating country will be El Salvador, and it will be run in May 15th. So if you want to join us, it's an open session. We are looking forward to engage clinicians from every country in Latin America or Spanish-speaking countries, so we can share this engagement tasks from SNOMED International, where Ian, Charles, and Jane are working in, so we can engage more clinicians in clinical reference groups or even in advisory groups. So all of you Spanish-speaking speakers and everyone from the SNOMED International community to join us on these webinars.
Thanks, Victor. I think the one thing that struck me about the Latin American network in particular is that there's a number of clinicians that have reached out and joined the network that aren't from SNOMED member countries. So I think one of the things with networks kind of stretch beyond the SNOMED community, if you like. So it's really looking at doing outreach to clinicians rather than outreach to, I'll call them the usual suspects in terms of SNOMED countries. So it gives us additional opportunities for outreach. Go, because I need to find the next slide.
I just want to add that Victor's done a fantastic job at putting these sessions together, getting speakers who've got experience of using SNOMED, and from different parts of South America. And each time he's getting over 50 people on a webinar, and this is just us starting. So these are 50 clinicians who didn't know much beforehand, and they've gone away. And what Susie's getting is more interest from South American countries. And that's what we want. And to empower the clinicians to start to ask for it, and to then be able to put pressure on towards usage locally and nationally. So I think that's good. And I had a brainwave the other night, and I can't remember what it was, so that'll have to come back to me. But I think our next area, we will try to do something similar to what we've been able to do, is in the Asia Pacific region. And I'm seeing Kate over there nodding, so I'm thinking, okay, you might have done something foolish there. But I think, you know, we've got even more diverse languages in that area, so that will be something we'll have to deal with. But we're going to South Korea next, and it may be that that's the best thing to do, is to start to look at that. So if anybody wants to get involved with that, can help, got any ideas, I think that would be great if you come forward. Thank you.
Oops, wrong one. Let's get on the right one. So like I said, so that's kind of a summary of where we are with existing CRGs and networks. But one of the things which we need to look at is what we do about these broader groups. So things like the pathology CRG. As I said, we've had a request for a surgical CRG. And you know, if I look at the content in the SNOMED release, having input from surgeons is fairly crucial in a number of areas. But the difficulty with something like a surgical CRG is the scope is so broad, it's difficult to know what the group would actually focus on. So I've put a set of slides together, really just to run through with you our thinking. The one thing I would say, though, at the start of these slides, none of this is set in stone. So these are our thoughts. What we're really looking for is input from the existing CRGs who know this because we've already talked to them about it, or you know, other people within the SNOMED community. For this one in particular, I don't profess to know all the answers, and none of us do. So this is really, these are our thoughts, nothing more. Oops. Hang on. So, like I said, we have at the moment we've got clinical reference groups. They're all topic specialty focused. The aim of the groups really is to review clinical content requirements, look at clinical bit around derivative requirements, so where there's requirements for ref sets, maps, etc. They're focused on a lot of the content issues, and each of the groups have an allocated SNOMED author really to work through those issues. We did it that way and invested resources, if you like, allocating authors to each team, because even though you know, the authors are turning up for meetings and it's taking them away in some ways from authoring time, the time saved down the line in terms of queries is very high. So it's worth their time and energy, if you like. The groups are open to any clinicians, but also not just clinicians from those areas. Anyone that really has an interest in the topic area. So they're just completely open groups. In terms of the project groups, so the project groups are task and finish groups. They're all focused on work items. They all have defined deliverables and timescales. They tend to be smaller groups, which is not surprising in that sense. So the difficulty we've got is really when we started, though that type of approach worked very well. Then we had what I've called changing requirements. So we have requirements now for more broader focus groups. And like I said, the one which we've had requests for recently is a surgical CRG, but also the existing pathology CRG would also fall into the same category. They're groups which really, they contain a number of subspecialties. So if you think about something like surgical CRG, there are lots of different groups that would come under that banner. The same with pathology. Pathology will pick up microbiology, histopathology, et cetera, et cetera. So if you look at it from the point of clinicians who want to be involved, I can see surgeons having an interest in SNOMED, but surgeons would only invest their time and effort in discussion items which interested them, which is not a surprising statement. The same in pathology. So, if your discussion items are all around microbiology, you won't get histopathologists join the call, not surprisingly. It's very difficult with a broader scope like that to actually maintain an engaging agenda. So, if think of it from your own personal point of view. If you're going to turn up to a group, you're going to invest time in that group. You're going to look at the agenda. Does it interest you? Does it engage you? From our point of view, right, there's an internal kind of requirement, if you like, that we have from the authoring team to build up a clinical contact database. So when the authoring team have particular questions around authoring new content or queries about existing content, who do they contact? So trying to build up a contact database is something which all three of us essentially have on our to-do list. So alongside this, as Victor's, Victor and Jane have just kind of reflected on, is this idea of building up clinical networks. If I look at this, so we're looking at this from SNOMED International's perspective, but actually individual SNOMED member countries are already setting up their own national clinical groups. Some of those are specialty focused, some are more general. So, for example, Switzerland. Switzerland have a SNOMED clinical group. It's not specialty focused, but it does bring clinicians together looking at what the national drive is for SNOMED adoption. As I've said, we've begun a pilot with clinical networks with the Latin American group with Victor, really just to look at the approach of how it works. The idea is initially is to run clinical webinars, really to get the interest up there, up and running. To start to encourage the conversation and discussions, we do that by creating a dedicated conference site, and we encourage people in each webinar to just put questions there. It doesn't matter what they are, they don't have to be very complex. It might be clinically focused, it might be implementation focused. It doesn't matter in some ways. It's about starting that conversation. Like I've touched on, the engagement is within individuals, not just within the SNOMED community, but also outside the SNOMED community. The experience has worked well so far. And as Jane touched on, the idea would be to use the experience we've had from the Latin American network to go global, so to speak. So the proposal that we've come up with is looking at really combining, in some ways, combining both approaches for these broader groups. The way I kind of conceptualize this is to imagine breaking the year down into quarters. So for each 3-month period, we would look at running 2 traditional webinars, 2 traditional clinical webinars focused on particular clinical focus within that area. We'd get, the presenters would be external, so this is not about SNOMED International doing it. We've done similar things around clinical webinars in general, so looking at articles have been, research articles have been written in major journals, looking at things which are very topical. So really running 2 webinars, really just to get people interested in interested and engaged, I guess. As I've said previously, part of the engagement process is also to have this dedicated conference site and to start the discussion. So post some questions, post some items which are of interest. Then essentially the third meeting after the 2 webinars would be more like a traditional CRG meeting, in the sense that we would then take the discussion items and issues that have been raised on the conference pages, and that would be the agenda then. As we started to grow that group, there are a number of themes which would come out of that in terms of either individual specialty focus or particular areas of interest. Some of those then we would develop into topic areas and may well, we'll come up with requirements. The requirements will go through the usual process that we have within SNOMED International, making sure we've got member agreements, going through the management team, raising awareness with the member forum, the General Assembly, etc. But we'd start off those then, if they're accepted as project groups, we would bring together the clinicians, a smaller group of clinicians from the main network, and they would be task and finish groups. So they have a clear focus. We know exactly what they're working on, the timescale that they're working on, and then we'd look at them delivering it, essentially. The discussion point, I guess, from our point of view, is really to throw it open to you as the community. So what I've just described is are there things that need clarification, is the first point. In terms of the principle, so not necessarily the detail, but in principle, the direction of travel, do you agree with it? Are there alternative ways of doing this? So I've presented to you a particular approach. I'm not, I don't pretend to be the global expert in this. It's mine, Charles, and Jane's view of this. It's not the only view. There are other alternative approaches of doing this. So, what are they? And then looking at, particularly within member countries, I guess, are there other groups, either within SNOMED or broader than SNOMED, if you're looking from the clinical perspective? Are there other groups, either nationally, regionally, or globally, that we can essentially link into to make this approach a reality? Do you two want to add anything to what I've just said?
I don't. I think we should hear from our audience either online or in the room before adding further complexity and so on. So, not from me.
So within the room, well, we'll do within the room first, because I'm trying to multitask here. So within the room, do you have any views on what I've just said? Kate? No, Ed. I'm just picking on Kate. No, do Ed first, Alison. Well, you always have a view. It's the way it is.
Thanks, Ian. Thank you. This is Ed Cheetham from the UK. I'm a bit concerned that you're perhaps conflating two forms of engagement, and this has been through the session, really. There seems to be a participation and development engagement and a usage appetite and enthusiasm form of engagement. The network, as described, the network experience in South America sounded like it was pulling people in who might be interested in SNOMED at the level of the user, where you're reporting stories of success and the benefits of use in practice. That's different to participant modelers and content, the people who are contributing their knowledge and experience and time as modelers. And I think they're different things. And one problem, the community who are interested in developing it are quite likely also to want to use it. But there's a much larger community who will be the ones for whom you're trying to create a real lust for the product. And I think those things are different. The title of the session about clinical engagement in the future, I thought would be more about the usage and enthusiasm group rather than the content development group. I can see that both are relevant, and I just worry that this proposal seems to conflate the two. I have got some other thoughts, but I'll just leave it at that for now.
Completely agree with Ed, but I think also what we're finding is within Australia, by building enthusiasm around the use, getting people engaged, we're also then identifying clinicians who do want to get down into the detail around the product as well. So I think they are two different things, but one helps get the other. I think some of the things that we're finding in Australia where we're getting much broader input and enthusiasm from clinicians is putting this in the context of building up our data models and our data models for interoperability and putting in the broader interoperability, data use, data exchange context, because that's then selling about why I need structured data and therefore where terminology fits as part of that. So I think in terms of how we can leverage other groups nationally, regionally or globally, is I know there's, in Australia and in a large number of countries, I'd say probably in the last 2 to 3 years is really increasing their activity around how do we build national data standards from a data interoperability point of view, not our national reporting standards, but our data use standards. So how can we hook into some of that activity as well and bring those conversations together so that the information data model conversations are happening in parallel with the terminology use conversations? And that's where we're seeing it. It's really fantastic. Our Allied Health Professional Association has reached out to us in Australia because we're developing AU CDIs, the Australian Core Data for Interoperability, and they've identified that they need to be there as part of it with terminology standards as well. So I think, some of it linking it into those broader conversations is bringing the clinical colleges to the table.
So online, Victor, you had your raise hand. You start again. Victor, you've got your hand raised. Do you want to say something?
Yeah, thank you, Ian. Maybe we should take a look from a different point of view, and this is the Latin American point of view exclusively, because when I started attending the CRG meetings, I haven't found any Spanish-speaking people participating in the CRGs, and that was the first thing that we talked about, Ian, when we planned to start the Latin American network, the clinical network. So we don't have any people from Latin America, or very few people from Latin America participating in the CRGs, and we need them to participate in the discussions and the modeling and the authoring and the implementation and all kind of issues that will impact them somehow. and how can we reach them? Well, we can start with the clinical networks so we can engage people, bring them to the discussions, and then start thinking about getting them to a CRG where they can participate in a more academic, researching, implementing, modeling way. That's my point of view, particular point of view.
Thank you. Jane.
I think Ian put these slides together. We have only just opened up this thing for discussion, and we sent out something to our CRGs, the CRG leads. We haven't had any discussion with them yet, and so I think what you said, Ed, was what I saw when I read the slide deck as well. And so I think it's really helpful to keep throwing this stuff in so that we can then go to the next stage when we talk to the clinical leads in May, because we're exploring this. This is genuinely exploring this. How do we do this? And I've seen the note from Gary, which is talking about also some crossover potential. I mean, this is way down the line, but these are options of looking at co-working with groups in HL7 and others, because the pot of people, we talk about our friend Andrew from anesthesia, who's no longer with us. He was a model of a clinician working across SDOs. And I think it isn't like we've lost it, but we haven't attempted to do any of that, trying to get our own base, get a base in place and support it. So I'm coming where you're from at the moment and just trying to think, okay, how do we go? So any comments are helpful, so thank you.
So I'm just trying to put my thoughts together here, but I'm going to come at this much more from a market standpoint. That's just what I do all the time, it seems like. I like the idea of the networks a lot. I think that getting people in understanding it makes sense. That's all logical. But I almost think like SNOMED may be a little too siloed already, even though we're a small organization, not just on dentistry being different from pathology, being different from something else, but our implementation group is now siloed from CRGs in some way or another. And I think one of the key issues is to how do we get the clinical information officers from the National Health Services, from the various things involved, and some way beginning to look at how they can structure their records in the electronic health record systems. And if we can get that stuff structured in some way, or at least get a group together to say, we can do it, then I think the clinicians who are key to that, who are the chief medical officers, are going to have to start learning this stuff and start working with others to advance SNOMED, because it is the best structure and it's got the best AI possibilities from everything I can see. So I'd like to see us look at getting those chief clinical officers, chief information officers at these major organizations involved somehow in how they can structure their systems. And they're going to have to learn how to use SNOMED too. But I think that's probably the best point of how we can get it. So I love the idea of us doing the implementation guides. But again, we're coming at it from clinicians that probably don't have the influential decision-making in the organizations that are deciding where we're going to go with our information systems. And I apologize, but I do come at everything in the marketplace.
That's okay. I know exactly what you like. Any other thoughts? Excuse me. I'm trying. I've got eyes everywhere.
Dare I mention money in this?
Yeah, thank you very much. I'll £20. Well, you paying us? Oh no, you. Yeah.
I mean, I never cease to be amazed by the generosity of people and their time. But for what is, I know you're a non-profit and that, but there's a lot of people, if you want to get a lot of people involved, that will be opportunity cost for them. Particularly people, clinicians, it could be opportunity cost. And this is not something you could turn on a sixpence, but going back to what I understand was the vision of the Galen project now 20 plus years ago, the idea then was to have expert clinician modelers, and their tooling approach was geared towards that, and their workflow was geared towards that. And I think they probably were talking in terms of volunteer effort. But if you want people to give their IP, give their knowledge and their time, then it might be worth at least tabling the idea of some form of, I'll call it micropayment model, that you and a tooling to support that there is some interplay between, in a sense, guardrails that your tooling would set up, and then people participating who have had a small amount of training, but then are then rewarded for the time and effort that they put in. If that has been that, I don't know if that's an obstacle, but I say I'm extremely impressed by people giving their time and seemingly asking for nothing but nothing in return. But I have seen this in relation to other ontology development exercises, that there are mechanisms for doing that now. And it's just something that you might want to consider if you're trying to get people with expertise to give their time to your product, whether there's a bit of a quid pro quo that might be worth considering.
I think, at the moment, the approach is more around the clinicians bringing their knowledge. And as I said earlier with the CRG groups, actually having authors who essentially do the modeling, I guess, do the modeling, author the content. In terms of the alternative approach, I don't disagree with you, but that is a different, that almost goes beyond this. That goes for more about the approach of content management for the organization rather than just clinical engagement in some ways, or clinical reference groups. I don't disagree with you. I think that needs a broader conversation, not least of which because it'll be Jim and the authoring team, not me. But I do think it's worth discussion, definitely. Marie.
Do you mind? Oh, I'm sorry.
Yeah, it's Marixandra. I just wanted to say that actually you get paid in a way as a clinician when you are contributing to a CRG because you get what you want. There is something missing in SNOMED and it is annoying you as a clinician, and you bring it to the CRG and you get it fixed, and you get it fixed firstly for yourself in a way, and it's fixed for all the rest of the world, and that's a nice side on. But actually, when you come to the CRG as a clinician, it's actually a bit an egoistic gesture. It's something that you get for yourself, and then it's also available for the rest of the world. So you get paid, and you get paid because you fix things that otherwise will be a hindrance for you, or a risk to your patient, or something that will cost you time. So there is some incentive, and there is some payment, but you have to think in payment in other words than money. I don't think rich and exceptionally brilliant clinicians will be interested in getting 50 euro per hour to sit in an expert group, because that's peanuts for them. But if you win them hours of time because it works better in the electronic health records, because they get the concepts they want to make their research and then publish a high quality paper and get their name on it and put that on their CV, that's how we have been selling, I would say, the clinical engagement model in the CSCT in Belgium. We've been running this for 7 years and not a cent has been given or taken by people who work in it. How does it work? It's simply because it fixes things.
And of course, I have to go down a little different road. But you brought up a really good point, and that was one of the things I meant to mention earlier, is that another one of my concerns as we laid out this and why I like the network better than adding more CRGs is my assumption, and I think it's a safe one, is that SNOMED probably has limited resources. And because you have limited resources, how far can you extend that and spend money developing more content when we can't have another source of income. So.
Kim Fong from U.S. National Library of Medicine. Just the thought kind of came into my mind when you mentioned monetary return, and then Maria said that, okay, everybody should be working for the common good. I think some kind of a recognition would be very nice. Like, I mean, can we think about some in-kind recognition like a CME accreditation? I mean, that will not cost actually money, but there's certainly a lot of things to set up. I mean, to recognize the time that clinicians devote to this important world of clinical data management. I think that may be something that's worth exploring. And CME requirements are quite universal, I think, among countries.
Thank you. I'm Gary Dickinson with, I'm co-chair of the HL7 EHR work group. And as I'm listening to this conversation, I'm reflecting on some of the work we've done over many years in our space. And we have actually developed functional requirements for EHR and HIT systems related to particular specialties. And that includes dentistry with the American Dental Association. It includes nutrition dietetics with the Academy of Nutrition and Dietetics, as it turns out. We're also working on behavioral health. We've done child health. We've done clinical research. We've done emergency care. There's a list of 25 or so different areas that we focused on. And we're currently in the process of updating our methodologies so that we're not only including functional requirements, but tying those tightly to data requirements for those particular domains and specialty areas or care settings or whatever it may be. And that then, of course, are pointing to FHIR, in this case, FHIR resources and elements within those resources. And of course, tying the vocabulary then to those same things. I mean, you could begin to see how this could be packaged in a way that you have not only the data requirements, including the vocabulary, as well as the functional requirements that systems would need to have to be able to support the particular practice in that particular specialty domain. And that and in fact, HL7 is currently supporting a new evolution in their tooling strategy specifically for this purpose. And so it seems like there might be a worthwhile conversation that could occur to see if there are ways to bring these things together and maybe do some efforts in common in some of these areas where we obviously have volunteers and interest.
Okay. So I'm going to bring the discussion to a close. Sorry, I'm going to bring the discussion to a close. Not close it down. So one of the things in terms of moving forwards that we need to do, both in terms of internally getting agreement from the GA and everything else in terms of the governance side, I suppose, internally, but also getting commitment from yourselves. So what we're going to do is open the discussion. So as Jane said, this is very recent. We put these things together. I'll start a discussion forum probably on the clinical engagement site that I showed you earlier. And we'll put out some notification via social media and via the website that that's gone live essentially. So we'd encourage you to put your points of view when I do that. In terms of as Gary's just said, so we'll follow up with HL7 and other contacts. But thank you all for your input into that item. While I'm finding the agenda, Jane, do you want to say something about clinical engagement? Clinical implementation, guys.
Yeah, I think, I mean, we've still got, no, is Scott there? No, he's gone.
That's all right.
No,
Right,
Scott.
put it back.
He's at the back. He's asleep. And, oh yes, or is he computing? Tina and Scott and Marie Alexander And they're actually our guinea pig. They've been our guinea pigs for the clinical implementation guides, with Marie Alexander and Bruce, who lead the Allergies group, doing the first one for Allergies. And I know it's a result of many years of work. And then that's already published. Scott and the Cancer Synoptic group, their work is being pushed into a clinical implementation guide, and that is going through QA at the moment. And Tina is working very hard on a clinical implementation guide to support the NCPT implementation of the NCPT content in SNOMED CT, which there is a RAF set release at the end of this month. And in fact, I think it's gone. In fact, I just saw it the other day. It's gone. It's published. It's very exciting this week. And the reason what we realised, and I mean the Allergies group realised it very much earlier than we did, was that you can have all this content, you've got all your ideas, but actually we've got to get a way of actually talking about the implementation end of it out to our groups. And of course we've got out to the world, and the clinical folks out there, and the people like the information officers, and how to implement this stuff. And if you take something like NCPT, which is based on a very clearly defined framework with relationships between things in the process, because that's what it means, national care process and nutrition care process, then it's even more important that they don't just get a ref set with a flat list, but they also get the background into what this is all about and where they can go to learn more and things. And I will ask Tina to add into it. But we're very excited about this, and I know which one we're going to hopefully do next. It's one with dentistry. And we've got the implementation team involved, and they've helped us put together the guide and the framework for it. So I'm hoping this will be a good way forward as well, because it's all very well putting the content into SNOMED, but if actually we don't make the relationship to where it is specific to something, like a framework, assessment and things like that, then it's not a lot of good really. Because Tina, do you want to add anything?
Yes, Jane, thank you for this great introduction in our beginning work on the implementation guide. We are very optimistic that we will create an implementation guide that will be usable by clinicians and developers alike, because we're looking to create a resource that is not developed in a vacuum. We are scoping out all the resources that we've developed. Somebody already mentioned the ENCPRS, or functional standard with HL7, which is a very important piece of healthcare standard for dietitians when they're advocating for their EHR. And we're also looking to add an actual experiential use case. We're working with people in Sweden to make that happen, where they are in a process of selecting an EHR and embedding NCPT in it, and we want to track them in their travels in that journey so that we can present their practical learnings in the implementation guide, as we think of it as a living document that we can update as new information becomes available. Thank you.
And I think she added, Tina, thank you, because you just added the vital bit, which was these are living documents. They won't be living as in we won't be correcting, adding every day, but we will be updating them as there's more experience comes through and correcting them. But and as Tina's pointed out, we've already started to do what Gary's talking about, is making the links to across into other standards in them. And that I think is vital. So, do you want to say anything, Scott or Marie Alexander? No, nothing you want to add, is there? No. Okay. No. Thank you.
Okay. So in the interest of time, because we've actually gone over time, which is always the case. Getting involved, I kind of covered earlier, which is the links, and we'll make the slides available, so you'll get the link. But just go on the Clinical Engagement website on Confluence, and you can get the links to all the groups. In terms of, like I say, in terms of moving this conversation forward with regards to network and the broader scope CRGs, we'll start that conversation and give you a mechanism for your to input into that discussion. So I'd like to thank all the speakers. I'd like to thank you, the audience, for your participation and your attendance, and also for those that have joined online. And thank you all, and I'll bring this webinar to a close.